Modern healthcare systems are publicly designed to optimize for equity, but they are forced to distribute care using strictly finite resources. How a system actually achieves that equitable distribution depends entirely on the academic framework used to design it. The leading theories prescribe mutually exclusive policies. If you analyze the problem through the lens of economics, medical ethics, or political science, you get three entirely different structural answers. The debate hinges on a specific tension. System designers have to decide whether equity is best achieved by maximizing an individual's right to choose, enforcing strict civic duties, or yielding entirely to macro-level state rationing. These theories collide because they disagree on the identity of the end user. Until a system resolves whether a patient is a demanding consumer, a responsible citizen, or a subject of state rationing, it cannot distribute care equitably. This matrix maps the core premise of economist Julien Legrand. Health behavior is a mathematical outcome of choices made under structural constraints. It plots patient power on the vertical axis against doctor motivation on the horizontal. The welfarist economic view positions the patient as a sovereign decision-maker. Place them high on the y-axis as a queen on the chessboard, receiving clean data to process their own utility perfectly. But this model hits an immediate constraint: information asymmetry, a concept defined by economist Kenneth Arrow. Patients lack the clinical expertise to accurately evaluate their own medical needs. A strict liberal economic approach bypasses this problem. It argues that the freedom to make medical choices is a good in itself, regardless of whether those choices lead to optimal health outcomes. If the patient cannot perfectly navigate the system, control shifts to the doctor. The horizontal axis measures their motivation, toggling the provider between a perfect altruist, or knight, and a self-interested actor, or knave. Assuming perfect clinical altruism ignores reality. Medical professionals, according to surveys of their own ranks, must constantly balance patient care against career advancement, family life, and leisure time. Once a provider acts on self-interest, even mildly, trusting them to act as the sole distributor of finite resources breaks the equitable distribution of care. Because provider self-interest is a permanent variable, economic theory concludes that the system must empower the patient to act as a sovereign consumer to protect individual welfare, even if catering to those demands strains the broader network. Ethicist Tom Sorrell rejects this consumer model. He argues that elevating the patient to a demanding customer forces the system to cater to short-term satisfaction over long-term stability. This diagram visualizes what Sorrell calls the two timescales problem in political management. You have a rapidly cycling 5-year electoral clock sitting right next to the 20-year clock required to actually build hospital infrastructure and train personnel. When politicians must answer to patients acting as consumer kings, they are incentivized to manipulate the 5-year clock. They divert money toward immediate, highly visible targets, stripping structural integrity from long-term projects to win the next election. Sorrell proposes an ethical alternative: the citizen patient. In a publicly funded solidarity pool, the user is not a consumer extracting value, but a citizen bound by strict moral obligations to the system itself. The first obligation is to minimize frivolous resource extraction. A citizen patient must recognize self-treatable minor ailments and refuse to consume scarce general practitioner time to address them. The second obligation requires rigid adherence to preventative public health advice. If a condition is preventable through diet, exercise, or nicotine cessation, the citizen is morally required to act on that advice before demanding medical intervention. The third obligation is temporal. Users must accept the bad luck of their generational timing, paying taxes to fund long-term infrastructure reforms that will likely only benefit the cohorts that follow them. Health equity is not a product that a state can simply hand to a population. It survives only if individuals actively ration their own demand through civic morality. Moving from the individual clinic to the macro-population scale exposes the mathematical limits of both the economic and ethical models. This graph models health economist Alan Williams' core trade-off. It plots clinical efficiency, maximizing the average health of a single patient, on the x-axis, against reducing health inequalities across a population on the y-axis. A clinician acting as an ethical provider for one individual patient pushes the slider toward maximum efficiency, but doing so diverts resources from the wider population, shrinking the total volume of equity across the system. Political scientist Rudolf Klein notes that without an infinite pool of money, patient sovereignty is a mathematical illusion. The system operates under a hard cap. In a system with a fixed budget, maximizing individual choice means highly educated, demanding demographics successfully extract resources at the direct expense of silent, passive populations. To manage this forced prioritization, the system relies on the Westminster model of government, where democratic accountability serves as the final rationing mechanism. This traces back to the architect of the British National Health Service, Aneurin Bevan, and his famous bedpan doctrine. Bevan centralized responsibility so completely that he stated if a bedpan was dropped on a local hospital floor, the noise should resound in the Palace of Westminster. This doctrine remains intact. When a local accident and emergency ward closes, the Prime Minister is routinely forced to explain that local rationing decision at the National Dispatch Box. The allocation of scarce medical resources ultimately bypasses the clinic entirely and lands in a highly concentrated political arena. Because national budgets are rigidly fixed, the conflict over who gets what and when cannot be solved by individual consumer choices. It is resolved through the blunt force of macro-democratic accountability. Relying on a single academic framework guarantees a fractured healthcare system. Pure economics ignores the reality of fixed budgets. Pure ethics assumes away the immense gap in clinical knowledge between doctor and patient. And pure politics reduces individual clinical needs to demographic statistics. Ethicist Alistair Campbell proposes a resolution, treating individuals as autonomous pawns. The three competing models must lock together. This means autonomy is not a life liberated from all constraints, but a system where mutual duties are met and maintained. Under this design, the patient steps down from being a demanding consumer and becomes a participant in a shared enterprise, accepting limits on their own care to protect the pool. In turn, the doctor is stripped of unchecked sovereignty, acting instead as a heavily regulated agent who must balance clinical need against systemic capacity. This structure provides the state with reliable, moderated demand, allowing politicians to allocate resources based on actual population needs rather than reacting to consumer panics or electoral cycles. Macro-level equity is impossible without enforcing micro-level constraints. An equitable system must respect patients as informed agents while rigidly bounding their choices against the cold mathematics of a finite public pool.